All right, so our first speaker is Masahiro Ozaki, MD, PhD. He is an assistant professor at Department of Orthopaedic Surgery, Keio University in Tokyo, Japan, and he'll be talking about cervical kyphosis after laminoplasty.
Thank you for introduction. I'm Masahiro Ozaki from Keio University in Japan. I'm grateful for this opportunity and appreciate cheers. Today's my talking theme is cervical kyphosis after laminoplasty for degenerative cervical myelopathy. I have no financial COI to disclose concerning this presentation. Degenerative cervical myelopathy, DCM, is the most common cause of spinal cord impairment in adults. DCM is caused by static compression by various osteoligamental structures, dynamic compression from abnormal spinal column mobility, and spinal cord tension from abnormal spinal alignment. Cervical laminoplasty was developed to overcome shortcomings of conventional cervical wide laminectomy. Several techniques were developed in 1917 and 18th in Japan. In 1973, Hattori and colleagues developed Z-plasty of the lamina. By this technique, defined from laminectomy, the lamina was preserved and reconstructed. But this technique was did not gain widespread acceptance because of its difficult technique. In 1978, midline opening French door laminoplasty was introduced by Dr. Kurokawa. Nowadays, this technique is one of the most common posterior cervical decompression procedure. In 1977, Dr. Kiyoshi Hirabayashi, the former professor of our department, developed a novel technique, expansive open door laminoplasty (ERAP). The idea of open door laminoplasty was evolved when we noticed the lifting of one side of the lamina would obtain dual pulsation. He developed this method. In the original method, the lamina is held open by suture suspension. However, laminar closure occasionally occurs due to the loosening of suture. Therefore, recently, we have modified our method and maintain the opening of lamina using mini plate fixation. Actually, the plate fixation decreases not only laminar closure but also postoperative C5 motor paralysis. Advantages of laminoplasty: low risk of adjacent segment disease, reconstruction and preservation of dorsal stabilizing structures, and limit ROM of cervical spine. In multiple cases, laminoplasty had lower complication compared with anterior surgery. Laminoplasty was also reported the favorable long-term outcomes. Dr. Chiba of our department have reported favorable recovery rate of JOS score was maintained at the final follow-up in 14-year follow-up study. However, Dr. Chiba also mentioned unsolved problems of ELAP at the same time. Their problems, segmental motor paralysis, progression of OPLL, and post-operative cervical kyphosis. Peterson and colleagues have reported the frequency of kyphosis after laminoplasty was about 20% in their systematic review. In addition, Sakai and colleagues have reported about 5% of patients without preoperative kyphotic alignment. Previous studies have reported the post-operative loss of cervical lordosis caused insufficient spinal cord decompression and the potential of the recurrence of stenosis requiring an additional surgery. Several studies have reported the risk factors of kyphosis after laminoplasty. Lee and colleagues have demonstrated that the cervical alignment during extension was a risk factor. The cutoff value of extension RM was 14 degrees. The cutoff value had a sensitivity of 100%, but relative low specificity, 52%. CGH C7 SVA was reported of one of risk factors. CGH is the center of gravity of the head, which is anterior margin of the external auditory canal. Sakai and colleagues have reported that the greater CGH C7 SVA was a risk factor of kyphosis after laminoplasty. Cutoff value of CGH C7 SVA 42 millimeters. This factor had a relatively high sensitivity and specificity, both around 19%. This paper was published this year. This is a Japanese multi-center study which investigated the risk factors of kyphosis after laminoplasty for OPLL patients. And the authors detected the risk factors were preoperative small extension ROM and large OPLL. The cutoff value for extension ROM and occupation ratio of OPLL were 8 degrees and about 14% respectively. And I provide you with actual case of kyphosis after laminoplasty. Case 1 is 44 years old male. His chief complaints were neck pain and gait disturbance. He underwent ELAP at C3 to C7 at another hospital 60 years ago. 1 month ago, he had the progression of neck pain and spastic gait. His past history was chronic nephritis. On physical examination, we observed left motor weakness, left leg motor weakness, left finger clumsiness, and left arm sensory disturbance, and hyperreflex of bilateral patellar tendon. This is an MRI before first surgery performed 6 years ago. X-ray is not available, so the details are unclear, but MRI shows the kyphotic alignment with C3-6 angle of 16 degrees. This is X-ray before this revision surgery. C3-6 angle has worsened, increasing to 38 degrees. MRI shows the recurrence of stenosis at C4-5 and C5-6 level. CT myelography shows findings similar to MRI. A hinge fracture was observed at C5 lamina. This patient was cervical kyphosis after laminoplasty and compression of spinal cord at C4-5 and C5-6. We planned to perform anterior decompression and fusion at C4 to C6 level. Post-operative X-ray shows the correction of kyphosis and improved it to 16 degrees of kyphotic alignment. Next case is 65-year-old female. Chief complaint was gait disturbance. Her past history is systemic lupus erythematosus. MRI shows multi-level stenosis at C3, 4, 5, and 5, 6 level, and extension MRI reveals the worsening of stenosis. Preoperative cervical X-ray shows cervical mild lordosis and sufficient extension ROM. CGH C7 SVA was 33 millimeters, which is below of cutoff value of 42 millimeters. Preoperative whole spine X-ray shows no particular coronal and sagittal imbalance. C7 SVA was 0 millimeter. We performed open door laminoplasty. We placed the mini plate on the lamina of C4 and C6. This is a method we commonly used. However, post-operative X-ray at 7 days shows the displacement of mini plate on C4 lamina. But this patient had no symptoms. And in retrospect, this X-ray showed the slight kyphotic alignment. We performed revision surgery. We replaced the mini plate on C4 lamina and added the placement of mini plate on C5 lamina. Postoperative X-ray shows a loss of lordosis, and C27 angle was 13 degrees of kyphosis. 3 months later, the kyphosis had progressed. C27 angle has worsened to increased 82 degrees of kyphosis. CGH C7 SVA was 117 millimeter. We tried hard traction for 4 weeks. Kyphosis was corrected to 16 degrees of kyphosis. After that, we performed a posterior spinal fusion from C2 to T4. Additionally, hollow fixation was performed post-operatively. We removed hollow rings 3 months after surgery. The alignment of cervical spine improved to a lordosis of 5 degrees. This is similar to a preoperative condition. A recent study has also reported the risk factor associated with surgical techniques. This study showed the association between the destroyed facet joint by mini-screw and the post-operative cervical kyphosis. A systematic review and meta-analysis showed the 6 risk factors, which were male, age, BMI, greater fractional ROM, lower extensional ROM, and greater CTH C7 SVA. I believe that it is important to conduct further multivariable analysis that includes these risk factors. In my conclusion, age, sex, obesity, and preoperative cervical malalignment would be the risk factors of kyphosis after laminoplasty. To predict accurately the cervical kyphosis after laminoplasty, it is crucial to conduct further multivariable analysis. Thank you for your attention.